is a conversation with life itself. Every step they take begins with our care and protection. Every breath they take is worth safeguarding with care. Because we understand, we give more care. RWD Respiratory Anesthesia Machine R660, designed for expert care and reliable protection. An all-in-one solution with respiratory anesthesia machine, oxygen concentrator, and monitor everything neatly mounted on the unit to save valuable space. Startup begins with an automatic leak check, keeping risks out of your way. Simply enter the weight and the system automatically recommends the optimal ventilation settings. Equipped with 4 ventilation modes to meet the needs of every surgery. At a glance. Powerful turbine-driven system requires no external gas source, offering greater flexibility in use. Colored airway pressure gauge design enables dual-circuit pressure monitoring, ensuring safe ventilation for animals of all sizes. Every high-precision vaporizer undergoes strict quality inspection to ensure safety. Beyond anesthesia, guardian of vital breath.
Originated in 2002, RWD has been constantly furnishing customers with reliable solutions and services in life science, animal health and clinical medicine, and dedicated for better vital quality within our wits and powers. Our products have been sold to over 100 countries and regions around the globe and won worldwide customer confidence and support. At RWD, we launched 6 solutions in the fields of life sciences, animal health, and clinical medicine at the forefront of the world, including animal surgery and modeling solutions, which ensure experiment efficiency through diverse animal disease modeling and model evaluation techniques. In vivo imaging solutions, which provide tangible tech support in fields such as biology, pharmacology, materiology, and translational medicine, among others, by accurately showing blood flow and changes in other indicators of live beings in visualized imaging. Neural signal research solutions, which are valuable tools for neural circuit analysis, as well as research into mechanisms for neural system diseases, development of brain-machine intelligence technology, and more. Histopathology solutions, which improve the quality and efficiency of pathological diagnosis while sectioning with high accuracy and efficiency. Cellular and molecular biology research solutions, which advance efficient scientific research through covering all conventional experiments, including cell separation and purification, self-culturing, self-analysis, and molecular biology. Animal diagnosis and treatment solutions, which evaluate diagnostic efficiency and treatment efficacy of surgery with anesthesia, dental services, rehabilitation, and physiotherapy, urinary system diseases, etc. And our assistants, science researchers, have published thousands of papers in a number of world-leading academic journals, including Nature and Science. On top of that, many scientific research institutions, medical institutions, and pet diagnosis and treatment centers have attained their success by leveraging our 6 solutions up to now.
So we've been collaborating and cooperating with RWD for quite some time now, and their self-developed products have helped us in the laboratory maintain accuracy and improve accuracy and help our efficiency.
As a national high-tech enterprise, RWD ascribes great importance to technology research and development. Based on 4 technical platforms, including optical imaging, precision transmission, accurate temperature control, and detection of weak signal. Since RWD's founding, the company has invested hundreds of millions on research and development, gaining almost 100 patents, both domestic and international, as a result. In addition to a sound manufacturing base, advanced processing assembly line, and precision detection system, RWD has built an integrated control system that monitors all aspects of operations from research and development to manufacturing. The name RWD comes from the transliteration of the English word reward, meaning payback to society. In 2016, RWD launched the RWD Preclinical Medicine Enlightenment Scholarship to help with the development of research talent in China's preclinical medicine. So far, the scholarship has been awarded to 38 institutions.
Good day, doctors. Welcome to RWD Vet Academy channel, and thank you for your attention. My name is Edwin Wu, and I'm the host of this webinar. RWD is a life science company focusing on animal health. Under more than 20 years history, we try our best to provide comprehensive service in anesthesia management and ventilation in practice, dental healthcare, and recovery option. RWD products are trusted by over 10,000 medical institutions in more than 130 countries. In addition to provide veterinarian with the superior product, we also looking up to spread knowledge from experienced doctor. So we launched this channel for medical technical communication. For tonight, the topic is practical ventilation strategies. We are honored to invite Dr. Matthew to share his knowledge and experience of the diseases and take us to explore more practical ventilation strategies. Here is a brief introduction of Dr. Matthew Hayer. He is the Associate Professor at Murdoch University and the Senior Vice President of Association of Veterinary Anesthetics. Now, I will pass the time to Dr. Matthew. Dear audience, if you have any question during this webinar, feel free to tap in the chat box or the question and answer module. Doctor will ask the answer after his presentation. So I will leave the time to Dr. Matthew.
Excellent. Well, thank you for the nice introduction, and thank you for having me today. I hope you can see my screen properly and the setups are exactly as you would like them to be. Otherwise, feel free to stop me and I will try something else. The goal of the session today is to talk about practical ventilation strategies. We will be looking at monitoring, troubleshooting, and clinical decision-making for safer anesthesia. So it's a huge topic that I will try and simplify for you. Before we start, I'd like to disclose that I have no particular conflict of interest relating to this presentation. So as Edwin said, I'm an associate professor at Murdoch University in Western Australia. I do have occasional collaborations with Mindray and RWD. And RWD does sponsor this webinar, but has had absolutely no involvement in the content. So I remain neutral in what I'm going to talk about. Few learning outcomes of the webinar today. So we have about 45 minutes or so, maybe a little bit longer, and I have all the time you need for questions afterwards. Learning outcomes, we will look at both oxygenation and ventilation in anesthetized dogs and cats. We will explain exactly what they mean because they are commonly confused by a lot of physicians. And we will evaluate or look at how to monitor oxygenation and ventilation clinically, which is a very important aspect of this talk. We should not go through anywhere near ventilation if we don't understand well oxygenation and ventilation, and if we don't know well and don't have the capability to monitor them adequately. We will then identify common causes of impaired ventilation, and I hope that you will be able to understand and relate them to your clinical practice. And we will try and apply appropriate troubleshooting strategies for those common causes of impaired ventilation. By the end of this webinar, I also hope that you'll be able to interpret the respiratory monitoring parameters to guide anesthetic decision-making strategies. And hopefully you'll be able to select and adjust, let's say, starting point ventilation strategies according to an animal and a procedural requirement. So let's first start with a little bit of physiology, and let's all breathe together. When we breathe spontaneously, it's important to realize that what we do is actually generate negative pressures within the thorax. The diaphragm contracts, the intercostal muscles also do contract, and that all in all increases the size of the thoracic cavity. By increasing the size of the thoracic cavity, the pleura expands and drags with it the lungs, creating a negative pressure within the lung. Because there is a difference between the negative pressure in the chest and the air pressure in the room, gases are dragged in. So during the inspiration, what happens is we will develop negative pressures within the chest, and that will generate a gas flow from the environment to the lungs. So the gas flow will originally be fairly high and then will be less and less high. As over the phase of the inspiration, the amount of gas kept in the lung will increase gradually, and we will end up at the end of the inspiration with the tidal volume. So on those graphs on the right-hand side of the screen, you can see pressure, flow, and volume plotted over time, and the red bar that moves from left to right represents the phase of the respiratory movement cycle we are in, as shown by the image on the side. So inspiration in mammals is an active phase that is built around having negative pressure in the chest at the beginning of the inspiration, at least. The expiration phase that you can see in blue here is a passive recoil, is a passive phase, is essentially due to the elastic recoil of the structures that get back to their original position, and by doing so they chase out the gas that was taken in the lung during inspiration. So try and get familiar with those diagrams of pressure, flow, and volume over time. The color code I will be using throughout this presentation is this yellowish for the, sorry, I'm going to use a pointer here. This yellow part here for the inspiration, that's not a pointer. Laser pointer, there you go. This yellow color will be representing the inspiration throughout this presentation, and the blue color will be talking about expiration throughout the presentation. So we are going to be interested over time in pressures, flows, and volumes. So if you breathe with me spontaneously, I'll try to remove my pointer here. When you breathe normally, let's do it 3 or 4 times, the amount of gas you bring in your lung and you expire from your lung is called the tidal volume. So you see on this graph here, the normal inspiration, normal expiration gives you an amount of gas that comes in and out the lung that is called tidal volume. If you do take a big breath on top of a normal inspiration, you see that you still have some room for more gas in your lungs. If I take a forced inspiration, like you see that on top of what is my normal tidal volume, I still have what is called an inspiratory reserve volume. That's an important bit to keep in mind, because when we will be ventilating with a tidal volume, we may have to play a little bit above what's the usual tidal volume, and that is not a big deal because our system is already prepared to deal with actually higher volume than just the tidal volume we inspire and expire over time during normal expiration and inspiration. In the same way, although a little bit less relevant in anesthesia, if I breathe normally, I still have a lot of gas left in my lungs at the end of a normal expiration, but I can force my expiration. Say, for example, if I want to blow the candles on my birthday cake, at the end of a normal expiration, I will still have some gas left in my lung, and I will be able to have to expire more volume than what I had expired during the expiration of my normal tidal volume. That is called expiratory reserve volume. So if I blow my candles on my birthday cake, I still have some residual volume in the lung that is called residual volume. During anesthesia, we will be very interested in the tidal volume, particularly when we talk about ventilation and mechanical ventilation. We will also be very interested in the fact that the system can accommodate a little bit more volume than simply a tidal volume, and that's normal and physiologic. And we will also be very interested in the amount of gas that is left in the lung at the end of a normal expiration. So the sum of expiratory reserve volume and residual volume, and together those volumes are called functional residual capacity. The functional residual capacity serves as a reserve of oxygen during expiratory pause or during apnea. So it's a particularly important volume for us. When we look at oxygenation, it's really important to understand well oxygenation and understand very clearly that oxygenation and ventilation are not the same thing, because we often get that confused. So I'm sorry, I'm going to talk a little bit about physiology. I hope you won't be too bored. I promise it's going to be quick, but it is going to be highly relevant for this topic. When you and I breathe room air, we breathe a composition of different gases, a mixture of different gases. Okay, we breathe about 21% oxygen, and we breathe about 78% nitrogen, with around 1% of other gases in the mixture. The Dalton law of partial pressure tells me that the total pressure of a gas, when the gas is composed by a mixture of different gases, is the sum of the partial pressure of the gases. So out of my 101 kilopascals of atmospheric pressure that I breathe in and out if I breathe only room air, I breathe something around 20%, 21% oxygen, so something about 20 kilopascals of oxygen. Okay, if I breathe normally, I put in my lung every time I breathe in about 20 kilopascals, so 21% of oxygen, and I still have 78% nitrogen. In the next step, so before even getting to my lung, this gas actually gets humidified in my nasal cavity, in the trachea, and so on. So if I look at the amount of oxygen I have in the trachea, I have a little bit less than what I have in the room. Why? Because the gases have been humidified before getting to the trachea. Going down in the lung, we will have other gases. We will have, in particular, the CO2 coming out of our metabolism, and that will further reduce the net amount of oxygen we have in the lungs, because, again, it gets, if you like, diluted by the presence of other gases. Once we are deep in the lung, we have essentially nitrogen, we have oxygen, we have a little bit of water vapor, and we have CO2. And the amount of oxygen we have in the alveoli is similar to the amount of oxygen that will potentially cross the capillaries and get to the arterial blood. So let's say that if we understand well the fact that the gases get humidified and that the gases get diluted by, in particular, CO2 in the lungs, and therefore the amount of oxygen we have will not be as high as in the room when we look at the composition of a gas in the alveoli, the amount of oxygen we get there is similar to what's going to be able to cross the membranes and the capillaries, and therefore will be similar to what we can potentially get in the blood. It's really important. Anesthesia is a simple topic as long as you remember that you have one job, and that job is to bring oxygen to every single cell of the body. So how do we do that? We make sure that we have a decent cardiac output, because the oxygen delivery is the product between cardiac output and arterial oxygen content. Oxygen in the arteries is transported. I know this formula looks a little bit ugly, but I promise you it's actually simple and you don't need to remember the formula. You have to remember one thing: the oxygen in the arteries is transported mostly, over 98%, bound to hemoglobin. Okay, over 98% of the oxygen that is transported in the blood is carried by hemoglobin. There is only a very small proportion of oxygen that is dissolved in the plasma, and that is less than 2% of the total amount of oxygen the blood carries. In other terms, once your hemoglobin is saturated at 100%, there is not much more you can do in terms of oxygenation if you want to increase the amount of oxygen you have in the blood. So the only thing you can really work on is work on the amount of oxygen you have in the lungs and the amount of oxygen that moves from the lungs to the blood per unit of time. But in terms of total oxygen content, whatever you do will have very little impact because, of course, if the hemoglobin is 100% saturated, you can't saturate it 200%, right? So the only thing you can do is increase a little bit the dissolved oxygen in the plasma, which is less than 2% of the total oxygen transported. Why am I spending so much time on that? Well, importantly, what we need to understand is that if we want to monitor oxygenation in practice, we need to focus on pulse oximetry. So it's going to be impossible to deal with the topic of mechanical ventilation and spontaneous ventilation in anesthesia without considering the use of a pulse oximeter. Pulse oximetry looks at the saturation of hemoglobin in oxygen in the arterial blood. So it's important before reading the saturation value, which is the one we are interested in, to ensure, so saturation would be this number here, is the percentage of hemoglobin that is saturated. We need to make sure that the monitor is actually looking at the right portion of the tissue because we are interested in the saturation of the hemoglobin in the arterial bed, and therefore we're interested in the pulsatility. So what we need to see is that the monitor is looking at the right thing. We need to see a good pulse curve to see if we can trust the saturation value that is displayed by the monitor. How can we monitor oxygenation in practice? Another method is also the co-oximetry, doing arterial blood gas analysis. That is a little bit more invasive, a little bit more expensive, a little bit more complicated, and I would say go as far as saying in the vast majority of cases, at least in small animals, it is not necessary. So your first priority in anesthesia, regardless of the topic we are talking about today, your main priority in anesthesia is going to be maintaining a saturation of the hemoglobin above 95%, which is what animals try to do when they are awake and breathing room air anyway. And I told you, and I hope I convinced you, and I hope it was clear enough, that there is very little we can do in the blood in terms of total oxygen content once our hemoglobin is saturated. So the one thing we can actually work on is increasing the amount of oxygen in the lungs before desaturation, if you like. So what I can do as an anesthetist very easily, I can increase the inspired fraction of oxygen. If you remember earlier, I told you that when I was breathing room air, I was breathing 21% oxygen and I was breathing about 78% nitrogen. And I told you I need the oxygen. The nitrogen is a little bit less useful to me at this stage. I also told you that if I do a sum of all the pressures of all the gases that are present, I get to my full total pressure of the gas I'm inhaling. So if I add some oxygen, of course, I keep the same pressure. I will remove some of the nitrogen, but I will increase the amount of oxygen I have in my lungs at the end of a normal expiration in the functional residual capacity. And what I do when I do that is essentially I buy time before desaturation in case of apnea or respiratory depression. And that's also the concept that is very interesting when we do pre-oxygenation in our animals. So how much time are we talking about? If we prevent breathing, if we make an animal apneic and that animal was breathing room air when it's a dog, it will desaturate in about 1 minute, 70 seconds. If I replace the nitrogen that was there by oxygen, 100% oxygen or something above 90% oxygen, and I prevent the animal from breathing, the animal will not desaturate before about 300 seconds, so 5 minutes. So keep in mind that as long as your saturation is okay, well, you can probably tolerate some apnea or some very low respiratory rate, and that will have no impact on oxygenation if you use inspired fractions of oxygen that are high enough. So on the topic of oxygenation, remember that your goal is to saturate the hemoglobin and make sure that the hemoglobin stays saturated over time. And the little impact you can have is by changing the amount of oxygen you have in the lung, not necessarily in the blood for the vast majority of cases. When we talk about ventilation, ventilation is a completely different story because ventilation actually does focus not on oxygen, but focus on carbon dioxide. In other terms, when we talk about ventilation is how does the body decide that it needs to take a breath? The mechanisms there are a little bit complex and I'm going to simplify them for you, but what's the most important aspect of the trigger of spontaneous ventilation is actually the CO2. Not directly, but because CO2 is acidic, if I increase the amount of CO2 I have in the arterial blood, I will decrease the pH of the CSF in the brain and in the central nervous system. Changes in pH of the CSF will cause an increase in H plus ions, which will essentially send a signal to the central chemoreceptors, and that will tell the medullary respiratory centers that the body needs to take a breath. So you well know that when you breathe in and out, you breathe in and out intermittently. When does your body decide to take a breath? Essentially, when the CO2 in the blood gets to a value that is a little bit too high, and the body therefore knows that it needs to take a breath to bring it down. So that's the normal control of ventilation. Okay? So how do we monitor ventilation? Well, we said ventilation is actually a CO2 issue. So we monitor ventilation using capnography. Capnography looks over time at the partial pressure or the percentage of CO2 in the gas at the connection between the ET tube and the breathing system. So the capnography will give us a lot of precious information, and in particular, the value we'll be interested in is the end-tidal CO2, which is the value of expired CO2 at the end of a normal expiration. And why are we interested in that value? Because that comes from deep down in the lung, probably where the amount or the partial pressure of CO2 is very close to the arterial CO2. And we are interested in that value because it is supposed to be an approximation of the arterial partial pressure of CO2, which is, as we said, the main determinant of ventilation. Normal values of end-tidal CO2, 35 to 45 millimeters of mercury if we breathe spontaneously and we are awake. And we can probably tolerate a little bit more than that without being worried at all. What we will be worried about is not having oxygen carried to the hemoglobin, because that is really needed for the metabolism. If we have a little bit of a higher CO2 for some time, it's generally not a drama as long as it's not too high, and we'll talk about that a little bit later. How else can we monitor ventilation in practice? We can also look at arterial blood gas analysis, particularly the partial pressure of arterial CO2, which will be a little bit more precise and accurate than the end-tidal CO2. But again, is quite invasive, quite expensive, and has the major disadvantage of not being a continuous measurement. So importantly, when you monitor oxygenation, what you want to monitor is saturation. When you monitor ventilation, what you want to monitor is capnography. So you need to have both if you want to ventilate properly. Again, it is absolutely essential to understand that oxygenation and ventilation are not the same thing. In some situations, an animal could have a normal saturation but be hypoventilating, meaning that the CO2 would be higher than what it should be. In some cases, the oxygenation may be poor and the ventilation may be adequate because an animal may struggle to bring oxygen in. That's mostly when you have very, very diseased lungs. And to try and increase the amount of oxygen they get in, they increase their respiratory rate because they have no other way of doing it, which means that they drop their CO2 down because the CO2 is a little bit more soluble and gets exchanged a little bit more easily. And therefore, you could have an animal that does not saturate, but or that doesn't have enough oxygen, but could be ventilating normally or even more than normally. So just a synthesis in terms of concept. Oxygenation is the process of getting oxygen in the blood. We measure it mostly using the pulse oximeter and the saturation of part of the pulse oximeter. The key point of oxygenation is that it reflects gas exchange efficiency in the lungs. It is affected by inspired fraction of oxygen and ventilation perfusion inequalities, shunt, and the diffusion, so how healthy your lungs are. Ventilation is a different concept, is the process of moving air in and out the lung to eliminate CO2. How is it measured using capnography and potentially arterial CO2 in a blood gas? Ventilation reflects alveolar ventilation. It's affected by tidal volume. It's affected by respiratory rate, dead space, and airway resistance. Is it clear so far, or do you need me to take a little break to clarify some points? I don't see major questions in the chat. Feel free to interrupt me, or to the RWD friends and moderators, if you see that some questions appear, please stop me and I'll answer them. So once you understand well the difference between oxygen and ventilation, we can actually move and progress in the topic. Most commonly in anesthesia, the respiratory failure we will observe will be represented by hypoventilation, causing hypercapnia without hypoxemia, okay? Most of the time, I hope you agree with me, the vast majority of the animals we see in anesthesia do have healthy lungs. If they have healthy lungs, they have a system that is fine and fit to bring oxygen from outside to inside. And as long as I increase my inspired fraction of oxygen, which I do in anesthesia, I have very little, no, I won't say very little, but I have not a too high risk of hypoxemia and desaturation. However, what I do with anesthesia is that I cause a lot of respiratory depression with my drugs, in particular the opioids, in particular the volatiles, in particular the combination of anesthetic agents and opioids together. And the depth of anesthesia will also be a major determinant in the respiratory depression. The deeper the anesthesia, the more respiratory depression we will observe. So what the respiratory depression actually does to the body is represented in this graph. If you remember earlier, I did show you a few slides ago that the body would, so I had the arterial CO2 partial pressure in the y-axis and the time on the x-axis. I should have introduced that a little bit earlier. Essentially, the metabolism keeps using oxygen and producing CO2. The CO2 rises. Once it reaches a certain point, that is too high, the pH of the CSF is a little bit too low. The chemoreceptors perceive that and tell the respiratory centers to take a breath, and my CO2 goes down. And over time, I repeat that again and again and again. What happens with anesthesia is because I induce respiratory depression for all of the reasons I've talked about a second ago, well, the new value of CO2 or pH that would trigger a breath may and will probably increase markedly. So instead of taking a breath where the body would normally take a breath, let's say, I call it arbitrarily here something around 42, 43 millimeters of mercury of arterial CO2. Well, maybe the new value is going to be in the mid 50s or even sometimes higher. And that means that the body will stay without taking a big breath for way longer than usual because simply the pH of the CSF is not dropping enough to trigger a breath. And that is because we have, with anesthesia and with all our drugs, we have depressed the system and we have changed the new value of threshold. So that's mostly what we observe in anesthesia. We observe a respiratory failure that is causing means hypoventilation, causing hypercapnia, but we rarely observe hypoxemia. Another issue we have in anesthesia is, remember the Hagen-Poiseuille equation. Remember that we intubate those animals most of the time, and that's a very good thing because that means that we have a good control of the airway, and that means that we are able to provide support and ventilation if necessary. That also means that we are able to increase the inspired fraction of oxygen, and provide them with volatile anesthetic agents, which is also a good thing. The downside of intubation is that instead of breathing through the diameter of our trachea, we have a narrower diameter. If I reduce the radius by about half, so if I reduce the radius of my pipe by 2, you see from that formula, you don't need to remember that formula by heart, but just be aware that if you reduce the radius by 50% in your airway, you increase the resistance by 16, because in the formula of the resistance, the radius is at the fourth. And that is not without any consequence, because high resistance will cause fatigue and will cause hypoventilation. So when we induce anesthesia, we need to be very mindful about the size of our ET tube. That should be a compromise between not damaging the airway, but being as wide as possible to limit the impact of our ET tube on the resistance. In addition to that, we connect the poor animals to a breathing system, and regardless of the type of breathing system, that will also add more resistance. If it's a circle breathing system, we'll have to move the valves, etc. So that's adding a lot of resistance, and resistance can cause fatigue. So one of the main focus when you induce anesthesia and looking at the topic of ventilation in general is always make sure that you pick a system that is fit for your animal and that has as little resistance as possible for that animal, and also make sure that you use an ET tube that is as large as possible, because that will give you a better chance of having spontaneous ventilation throughout the case, because having less resistance will mean that they don't get exhausted because of their ventilation so quickly and easily. Anyway, we still have a little bit to consider there, because even if we do everything in the best possible way, it is not unlikely that during anesthesia we will need to use ventilation. So as I said earlier, we'll have different categories of changes in ventilation. Mostly in anesthesia, we will observe a decreased ventilatory drive because of the anesthetic agents, potentially in some cases because of intracranial pressure issues or central diseases of the central nervous system, and also in the long run because of hypothermia. In addition, sometimes we will be facing situations where there is a pure inability to ventilate. For example, I started the presentation talking about spontaneous ventilation and telling you that in spontaneous ventilation we would have normally negative pressure in the chest. Well, if I open the thorax, I cannot have negative pressure in the chest because the pressure in the chest will be the same as atmospheric pressure. So an open thorax is an absolute inability to ventilate, and there's no question there. We need to ventilate when we have an open thorax. Same if I give a paralytic to an animal. If I have an animal with phrenic nerve paralysis, pneumothorax, myasthenia gravis. So in some cases, you'll have inabilities to ventilate, and in those cases, there is no question we need to ventilate. In some cases, we will have a decreased ventilatory drive, and the question is a little bit blurrier and less clear-cut off in terms of answer. So I will talk about it in a second. So ventilating or not ventilating. The advantages of ventilation is that we will have a more accurate control of respiratory variables in general. A constant CO2 contributes to stable pH in the plasma and stable plasmatic concentration of potassium as well, which is probably an interesting and relevant thing. The regular rhythm of ventilation will depress the ventilation, increase the narcosis, and therefore, from a surgical standpoint, probably improve the operating conditions. A constant tidal volume allows us to monitor compliance of the respiratory system, which is an interesting topic per se. I've done my full PhD on this topic, so I like it a lot. Whether it's clinically useful or not is another question. I would go as far as saying in the majority of cases, probably not, but still something I like to mention because it's a topic that is particularly dear to me. In addition, and not last but not least, mechanical ventilation frees the anesthetist for other duties. And you know, when we try to multitask, it's not a bad idea to have free hands and a problem less to deal with. However, of course, as everything we do, there are advantages, but there may be disadvantages. The biggest disadvantage of mechanical ventilation is that because we are using positive pressure as opposed to negative pressure in the chest, we will have a major impact on the cardiovascular system, and we will definitely reduce the venous return and therefore the mean arterial pressure. And I told you earlier, it's really important to make sure that during anesthesia, we maintain an oxygen delivery to every single cell of the body. That comes with having enough oxygen, having saturated hemoglobin, and having enough arterial pressure to move that hemoglobin from the lung to the tissue that is using the oxygen. So it's really important to keep that in mind, because when we talk about ventilation, we cannot really ignore the fact that when we use positive pressure ventilation, we will have an impact on the cardiovascular system. Another possible disadvantage with ventilation is that one could create lung trauma, and that's really hard to monitor and to identify, and that's going to be even more likely if inappropriate variables are set, which is quite easily done. Excessive pulmonary stretch may potentially cause bradycardia. That's something we see on a regular basis. You could have, of course, the risk of mechanical failure, which is less likely if animals are breathing spontaneously. And of course, you have the purchase and maintenance cost of your equipment. There is not a single ventilator in the universe that is suitable for all sizes of animals, as you could imagine. And ventilators may become fomites and harbors of transmissible respiratory pathogen, which is also something to consider. So I have, if you like, advantages and disadvantages. And one of the key questions of this presentation is, well, when actually should we consider initiating controlled mechanical ventilation? The answer is fairly simple. If you have an absolute indication, so all the causes of alveolar hypoventilation when we talked about earlier, like potentially open thorax, paralysis, the phrenic nerve paralysis, and so on, and probably raised intracranial pressure, I would say yes, we ventilate, no question asked. For all of the other cases where we said the hypoventilation comes from the respiratory depression caused by anesthesia, well, we will have relative indications, and we will need to establish a cutoff value at which we are not comfortable with, and that cutoff value is actually controversial. Most anesthetic agents are non-selective of the central nervous system, and most of our animals will be receiving opioids, so most of them will hypoventilate. And the need for mechanical ventilation should be based on a multi-system evaluation. If there is no absolute indication, my first advice to you is stay away from mechanical ventilation and try and make your anesthesia a little bit lighter, and try and see if you can get away with it without ventilating those animals using a ventilator. Personally, I use about 60 millimeters of mercury of end-tidal CO2 as my cutoff value. I tolerate end-tidal CO2 between 45 and 60 millimeters of mercury in most animals. We'll talk about it a little bit later. And I will start ventilating if really by lightening my anesthetic depth, I don't have an end-tidal CO2 that drops back below 60 millimeters of mercury. And why am I telling you what I've just said about try and stay away from using a ventilator? Well, because understanding how ventilator operates and their capability and limitations is essential. But as clinicians, we normally focus on animals. And as clinicians, our focus is the animal, but our instructions are expressed in physiological terms. But for the ventilator, which is going to be our interface, the ventilator will execute mechanics and will translate what we try and think about in physiological terms as variable flows through open, partially open, or closed valves to try and convert those physiological terms into what the animal needs, still receiving information and feedback from the animal and integrating potentially that feedback to the actions taken. So the job of a ventilator seems very simple and seems very simple to us because we think about it simply in terms of physiology. But the job of a ventilator is actually really, really complicated. Moving on. When we look at the ventilatory cycle, so I have decided that I need to ventilate an animal. and that I'm going to use an automatic ventilator. When I look at the ventilatory cycle done by a ventilator, there are 4 things to consider. The first point is the control variable. Which parameter do I want to guarantee? So I have 2 options there. I will talk about them in a minute. I can decide that I want a given pressure throughout the inspiration, or I can decide that I want a given volume in the lungs at the end of the inspiration. Once I have decided the control variable, so either pressure or volume, I also need to think about how does a breath start? A breath starts with a trigger, and the trigger could be the time. If I decide that the animal will start an inspiration every 5 seconds, 10 seconds. But I could also say that the ventilator could help the animal when the animal wants to take a breath, and therefore the trigger could be an inspiration from the animal. The third parameter essentially to consider in the ventilatory cycle is the limit. The limit is what the ventilator looks at and looks for during the inspiratory phase that would make us uncomfortable enough to discontinue the insufflation of the lungs during that time. For example, if I set a volume of 500 milliliters of tidal volume to a cat that is 3 kilo, of course, I realize that it is far too much and I'm gonna make the lungs of this animal explode. But before this damage on the lungs and on the animal, what will happen is that the pressures will go up quite a lot and quite markedly. And the ventilator may perceive those pressures going up too much and may say at a limit, I'm not going to continue the insufflation up to 500 milliliters despite what the anesthetist has told me because the pressures are too high. I'm going to stop there, and that is called the limit. And finally, at the last point of a cycle, a respiratory cycle is how does the ventilator transition between inspiration and expiration, and how does inspiration terminates, if you like. So important, when I deal with the mechanical ventilator, I need to decide when the inspiration starts, what I want to control during inspiration, and when those inspirations stop. Very commonly, I'm going to talk only about controlled ventilation today. Controlled ventilation is essentially simplifying the trigger. The trigger is going to be the time I decide when the animal takes a breath. So I control the inspiration from beginning to end. I have 2 ways of doing that. I can use pressure control ventilation and I can use volume control ventilation. That means, again, in my control, during pressure control ventilation, the pressure is what I set. So I said during the full duration of the inspiration, I want a pressure of 8 or 10 centimeters of water, and the ventilator will do that. And then the expiration will be passive. In volume control ventilation, what I will do is essentially say, I want this tidal volume to be administered during this time, and the ventilator will give me a flow that achieves that. When I use volume control ventilation, I can either use volume control ventilation without an end inspiratory pause or with an end inspiratory pause, where essentially the tidal volume could be insufflated over a shorter duration compared to the full inspiration, and that would potentially allow to some of the gases to redistribute a little bit better in the lung. Important point, and I see, and I will talk about it again during the questions, because I saw that someone asked a question in the chat a little bit earlier about the influence of resistance on the barotrauma and the pressures. Well, you have to remember that when I use positive pressure ventilation, I measure pressure again at the level of the ET tube, if you like, and the level of the ET tube is also where my narrowest point in the airway is. So the airway pressure I measure is generally higher than the alveolar pressure. The resistive pressure never really affects the animal. It really doesn't exist in the animal. What exists in the animal is only the elastic pressure. So whatever pressure you read on your ventilator is not really representing the alveolar pressure. The alveolar pressure is going to be a little bit less than that unless you continue your inspiration for a very, very long time. So now I'm going to talk about both pressure control ventilation and volume control ventilation. In volume control ventilation, my trigger is the time and my cycle is the time. So I decide the duration of inspiration. I decide when it starts, when it stops. And in volume control ventilation, what I decide is essentially my tidal volume. I decide a tidal volume, but the ventilator understands a flow over time. So once the tidal volume is decided and the duration of the inspiration is decided, the ventilator will convert that into a regular square wave of a flow throughout the duration of the inspiration. So what happens over time? My flow in volume control ventilation is a square wave and is continuous throughout. Pressures increase as the gas is going in the lung and stays in the lung, and at the end of the inspiration, I have my tidal volume. So what do I set when I set a volume control ventilation? I set my tidal volume. Generally, most people will start with 10 milliliters per kilogram of tidal volume. I set my respiratory rate and either, depending on the ventilators, my inspiratory time or the ratio between inspiration and expiration, which will give me the inspiratory time. I also have the option of setting an inspiratory pause. So if I want, I can actually have a flow that is a little bit higher for a time that is shorter than the inspiration and have, despite being still in inspiration, a time of no flow. In that case, the tidal volume will be reached faster. So that's what happens here. You see in inspiration, if I have my insufflation volume control ventilation throughout the duration of the inspiration, I have a square wave and the insufflation happens throughout the inspiration. If I have an end inspiratory pause, I have a flow that is a little bit higher for a similar tidal volume, but then I have a little period of no flow. And what that changes is essentially the pressures. I will have in volume control ventilation with an end inspiratory pause, a peak pressure and a plateau pressure. And the peak pressure will be the pressure only in the airway. The plateau pressure, if I leave it for long enough, may represent a little bit better the pressure at an alveolar level. What do we need to look for when we use volume control ventilation? Well, you need to look for pressure. What's going to happen is that the ventilator will give you the tidal volume you desire regardless of what happens. And what you need to look for is changes in pressure. If, for example, the resistance increases, my flow will still be the same, my tidal volume will still be the same, but what will increase is the inspiratory pressure. If it's particularly an increase in the resistance, I will increase only my peak inspiratory pressure, but the plateau pressure is probably not going to be altered because the gas, there's no problem at an alveolar or at a lung level. My problem is really the resistance before that. If I have a change in compliance, what will change is my plateau pressure, and therefore both peak pressure and plateau pressure will go up, but regardless of changes in resistance or in compliance, the tidal volume will remain stable because the flow will not change. It's very different compared to what we observe in pressure control ventilation. So when I use pressure control ventilation, what I set is actually a pressure during inspiration. I decide that I want 7, 8, 10 centimeters of water throughout the duration of inspiration, and the ventilator will do that. So we will start with a higher flow, but to maintain that pressure, the flow it needs per unit of time during the inspiration will be less and less. You may even stop. What do I set when I set the pressure control ventilation? Well, trigger and cycle are going to be the time. So I set the respiratory rate and either the inspiratory time or the ratio of the duration between inspiration and expiration, and I set my pressure. In that case, when I set a pressure control ventilation, what I will have to watch out for are the volumes. If my compliance decreases or my resistance increase, well, you will be able to accommodate less gas to get to the same pressure. And therefore, in both cases, you will have a stable inspiratory pressure because that's your setting. But what you will end up having is less and less flow as respiratory compliance or compliance decreases or resistance increases. And you will end up having a very low tidal volume, which is particularly problematic. So when I look at pressure control ventilation, I actually consider monitoring volumes. So all in all, monitoring is primarily important because you need to know when to initiate ventilation and you need to adjust your ventilation based on your monitoring. So when you look at the topic of ventilation, it's absolutely out of the discussion of doing that without having a pulse oximeter and without having a capnograph. We will be looking at pulse oximetry and saturation, and we will be looking at capnography. we will be looking at respiratory rate, and that comes also with an animal assessment. The most important part is the animal assessment. So how do I decide how to set a ventilation mode regardless of the one I'm using? It can be pressure control ventilation or volume control ventilation. I start with a value probably around 10 mils per kg tidal volume in pressure in volume control ventilation, and probably around 10 centimeters of water. So I always start with a 10 anyway in pressure control ventilation, and I look at my animal and I watch the chest excursions. Very important. How does the chest of that animal move? Does it move? Does it look physiologic or does it not look physiologic? If it looks like what the animal was doing beforehand, it's good. If it looks too much, well, I'll back off a little bit my volume or my pressure. And if it looks like it doesn't move enough, then I will increase it to make sure that it remains physiologic. And what I need to look for when I do that is to look for changes in airway pressure. In terms of troubleshooting, what's really important is to use a systematic approach. So when you have low saturation, which is not so common, check the oxygen source, check the equipment, and check that the animal is actually ventilated. If you have high end tidal CO2, check for hypoventilation. What can cause that? Resistance, drugs, all of it together. Is there anything you can do to make the animal's life a little bit easier? Try and reduce anesthetic depth. See if you can use lighter weight equipment and less resistance. A low end tidal CO2 is not something we see very commonly. So when you see that, you could be hyperventilating or you could have a cardiac output issue. You could also have leaks. So make sure that when you have a low end tidal CO2, you check for leaks and you check the cardiac output and the overall animal. And if you don't find anything else, then you can reduce your ventilation a little bit. Airway pressures, we say it's important to monitor airway pressure when we use positive pressure ventilation. Well, when they increase, check for obstruction and check for potentially changes in compliance and resistance. When the pressure is too high, reduce your tidal volume one way or another. In terms of ventilation strategy, that has to be adapted to the animal. Again, what I told you earlier is that I consider permissive hypercapnia, which is an end tidal CO2 of 45 to 60 millimeters of mercury, appropriate in the majority of animals, unless I have an absolute indication to reduce it, which is not so common. Protective ventilation. Anesthesia and recruitment and PEEP is probably a topic for another day because it would take me another full hour to go through just the simple basis of that, so let's avoid. What matters in practice is that, as we've said earlier, the mechanical ventilation will have a major impact on the cardiovascular system and the cardiovascular function. And we said it's very important to have a continuous multi-system evaluation. Ventilate only when it's necessary and monitor diligently absolutely everything, including saturation, capnography, and blood pressure. Your ventilation, as well as airway pressure. Your ventilation will have an impact on blood pressure. If you have a major impact on blood pressure, you will not be able to bring oxygen to the cells, which is going to be problematic. So my simple recommendations to you: try and limit the resistance of the respiratory system, choose your ET tubes well, and choose your breathing systems well, and try and refine anesthetic depth, being always at the latest possible stage you can tolerate, and that will give you a better chance of animals breathing spontaneously. If you have to use mechanical ventilation, as much as I can, I prefer to use volume control ventilation because that will give me a guaranteed tidal volume and a guaranteed minute volume. That's going to be easier to monitor, and it will be a little bit more reliable because if I use pressure control ventilation, just the surgeon's hands on the chest of an animal may be enough to cause changes in tidal volume that I may or may not be able to detect easily. So personally, if I can, I use volume control ventilation. There are cases in which you can't. For example, when your tidal volume, your minimum tidal volume on the ventilator is higher than what you want to administer to an animal. So that can be the case for very small animals like rabbits, mini kittens, and mini puppies. Then, of course, you may have to use pressure control ventilation. But otherwise, I'd say if I have to start somewhere, I start with volume control ventilation. I start with a tidal volume of 10 mils per kg, and I observe chest excursions because I want them to remain physiologic. My inspiratory-expiratory ratio, which is, again, the ratio between the duration of inspiration and expiration, I set 1 to 3 because I increase my resistance with the ET tube, and that's going to be an expiratory issue. So I really want to make sure that all the gas that I push in the lungs during inspiration has actually enough time to get out during expiration. And I choose a rate that is close to baseline. Once I have all that setting and I'm happy with the chest excursions, I of course keep monitoring the inspiratory pressure and the airway pressure with the goal of keeping the pressures below 25 centimeters of water. We've talked briefly about the trigger. Personally, I do not recommend using assisted or supported modes in anesthesia ventilators, and we can revisit that and rediscuss that either later during question or at another time point. So, good ventilation is not just about numbers, it's about integration, interpretation, and intervention. You need to monitor continuously, troubleshoot systematically, and individualize to every single animal. Think about the animal's issue. What is the problem? What are the problems? And is there a way to eliminate the problems without being more interventionistic? What does the monitor and the animal tell me? Plan. What's your goal? What strategy? What can I change? How will that help? And what are going to be the consequences of that? Act. Well, put in place your change and see what happens. That comes, of course, with reassessment, checking, monitoring the animal. Did your intervention work? Did it work the way you wanted, and did it come with unexpected consequences? And from there, continue to adjust. So I hope this was clear on what you are expecting, and I'm happy to take questions. Again, I have no time limit for questions, so use this time to ask anything you want. And I want to thank RWD for their support and this opportunity of discussing this fascinating topic today, because it's really important to talk about it and to spread good information and add physiologic information to a topic that seems simple but isn't.
Okay, so thank you for doctor's wonderful speech. And now we have 4 questions in the six one in the
Oh,
column. So you can ask them one by one. I will leave the time for you. Okay.
excellent. Oh
So
yeah, I
start
was
start
seeing the,
from. Okay. Can you stop? Can you see the question?
yes, I have them. I was just looking at the chat, not at the Q&A. Sorry, so I missed that. So Henry
Oh.
asks, high resistance also increases the risk of barotrauma, right? Due to increased peak inspiratory pressure secondary to airway resistance. Your increased resistance most of the time is actually an expiratory issue. So your issue is going to be your increased resistance will increase the peak pressure, but the resistance does not really, the resistive pressure does not really exist in the animal. The resistive pressure, if you like, exists in the airway, but does not exist at an alveolar level. So let me share again that slide with you, because that's one of the slide I presented earlier. See, if you use, for example, I'm going to take the case of pressure control ventilation. I tell the ventilator that I want a given pressure in the airway throughout inspiration, and it will start a little bit slower and then will maintain that pressure over the time of inspiration. If I increase the resistance, I will still have the same pressure. But what's important to note is that the pressure in the alveoli during the time of inspiration will increase more gradually than the pressure you see in the ventilator. And that is because of the resistance. So a lot of the component of the pressure you see is actually the resistance. And that does not mean that the resistance or the resistive pressure has an effect on the alveolar pressure. It will reduce the volume in pressure control ventilation, but it will not have an effect on the alveolar pressure. And therefore, no, if you have resistance, you don't really risk per se barotrauma directly. The only case where you would actually risk barotrauma is if your increase of resistance is so high that you don't leave enough time for expiration. So if you don't leave enough time for expiration, you keep adding volume in the lung without letting enough time for the gas to leave the lung, then yes, you could create barotrauma. But that means that probably your expiratory time is too short. So yes, you have a combination of high resistance and a too short expiratory time, but it's not an effect of the increased peak inspiratory pressure, if it makes sense. Does that answer the question? I'll take it as a yes. So next question. May I know fresh gas flow affects delivered tidal volume in volume control ventilation? Is it the reason why sometimes the ventilator delivers higher tidal volume to the patient that exceed the set tidal volume? That trying to digest. I'm sorry. We can take it slower later if you want, Henry. The fresh gas flow has the potential to influence the tidal volume on certain ventilators. It really depends on the arrangement, on the type of ventilator. It's really equipment dependent, and it depends on where your common gas outlet and your fresh gas flow gets to the circle breathing system, assuming that you are using a circle breathing system. So yes, it's possible. It's not the case in all ventilators, but it is in some ventilators, and that depends on actually where your fresh gas flow is connected in relation to your reservoir bag or your ventilator. So yes, it's totally possible. Another question is, if the patient is breathing against the ventilator under general anesthesia, would you consider to deepen depth and take over breathing completely? I tend to consider that Mother Nature is smarter than I am. I am not very intelligent, and Mother Nature is very intelligent. So if an animal is breathing against the ventilator, it's probably because I'm not doing a good job. So generally, the first thing I try to do, unless I have an absolute indication, is I switch the ventilator off and I see how the animal does without my intervention. If I really, really must ventilate that animal, which could be the case sometimes, I often have the case when I use in CT scan, for example, when you need to do CT scan of the thorax in some animals that breathe really fast, the diagnostic imaging people will want to have a breath hold for the time of their acquisition of images. And in that case, yes, sometimes I would probably either make anesthesia a little bit deeper or give a little bit of an opioid to depress further the ventilation and take over myself. And sometimes I will paralyze those animals. But I'd say the right way in simple cases, non-complicated cases, try and see how they would do without you, because it's possible that they would do a better job than what you are doing. The next question is, may I know what's your approach during the end of surgery before extubation? Would you recommend to maintain the patient on mechanical ventilation to breathe out the inhalant as much as possible? That's one good strategy. It really depends on your logistics and where you recover the animals. I'd say if I want a fast recovery, I will probably switch the volatile off and ventilate a little bit to drop the amount of volatile through my mechanical ventilation before stopping the ventilation. But in some cases, if I want a slower recovery, I probably will disconnect the ventilator, move away to where I need to go, and let the animal deal with it wherever. If I have an apneic animal during the transition from mechanically ventilated to a spontaneously ventilated animal, I generally do not ventilate until they show signs of early desaturation. So when the saturation starts to drop, I give them a little breath, but otherwise I probably will just let them be apneic on the basis that I generally have a lot of oxygen available. Have saved a lot of time there. Again, it really depends on your setting. Next question is, what is your own contraindication for ventilation? Contraindication for ventilation, that's really interesting. Yes, there are a few cases where I tell people around me that I really don't want to ventilate those ones. And I'd say most commonly the cases I will tell that about are the ones that have bullas in the lungs, because I really don't want to pop the bulla. but I never know what kind of pressure would would potentially pop them. And in some cases, if you have like a very mild pneumothorax but no tension pneumothorax, I'm a little bit more hesitant because I don't want to make the situation worse and end up with a tension pneumothorax. So animals with chest trauma that don't have a massively accumulating pneumothorax. I'm ready to drain the chest anyway, but if I can stay away without being too interventionist and worsen my damage, I will do that. I rarely have an absolute contraindication, but there are cases in which I prefer not to. Justin, why do you use 6 to 8 mils per kg for lung protective ventilation when that could be the volume of the dead space? That's a very good question. In fact, I wrote it, but I said that's mostly for ICU. I really don't use it in anesthesia. You would use it in the very few cases where you have very diseased lungs. So the typical case where you would use that is a case that actually is an ICU case and not a typical anesthesia case. You would use lung protective ventilation in case of acute respiratory distress syndrome, for example, or anything that gives you massive lung inflammation and lung issues. And in that case, you are facing the concept of baby lung, if you like. So you have, you'll ventilate the tissue that can be ventilated. But I definitely, in veteran anesthesia, stay away from it. The reason why I mention it is because in some countries, it became the norm in human anesthesia. Why? Because a lot of the people will stay in their bed for very long after anesthesia, and it's been shown that using lung protective ventilation with recruitment maneuvers and positive and expiratory pressure, you may have better outcome at 30 days post-anesthesia. So a lot of the human anesthetists will use that, and it becomes relevant to us when we start working with human anesthetists on research projects because they want to apply their ventilation strategy to our cases, which can become problematic. So that's why it's still there. Personally, I stay away from 6 to 8 mils per kg for lung protective ventilation, particularly in dogs, because in dogs, of course, if they have healthy lungs, you are ventilating dead space and that's it. For the reservoir bag calculation of tidal volume times 6, do you think this is excessive? How do you calculate the bag size in your experience? I think to the students these days, I say tidal volume times 3 at a minimum. But the reality is what I want to do is to be able to give a breath and accommodate for leaks. So my way is not very academic. I go ballpark, I look at the bag, look at the animal, say, do I have a couple of tidal volumes in there? Yes, that's fine, and I'll use that. Pedro, why don't you recommend synchronized intermittent ventilation, and what do you think about pressure control volume guaranteed ventilation modes? Very interesting question. Why do I not recommend synchronized intermittent mandatory ventilation? I'm gonna make a very long story short. When you use synchronized intermittent ventilation, you rely on the ventilator recognizing an inspiratory effort from your animal. So your trigger will be, on the synchronized intermittent mandatory ventilation, you have controlled breath that happened at a time you set, but you also have breath that in which the ventilator will help the animal that tries to take a breath. So your trigger becomes the animal. When you use an ICU ventilator, I use synchronized intermittent mandatory ventilation in ICU ventilators. The ICU ventilators and the anesthesia ventilators have very different designs. An ICU ventilator is built around having always a flow through it, and the flow can be bigger or smaller, but the way the ICU ventilator will detect a breath from the animal is a difference between inspiratory flow and expiratory flow, and that's very fast to detect, and therefore when they detect that, they can massively increase the inspiratory flow and help very quickly. An anesthesia ventilator has been developed around the use of volatile anesthesia and therefore the use of a plenum vaporizer. And you cannot use high fresh gas flow in anesthesia ventilator because otherwise your vaporizer will not cope with it. So what we are designed to, our systems are designed to recycle the gases, and therefore as opposed to an ICU ventilator, you have a very low flow in a normal anesthetic system, and your movement is given only by the ventilator or by the animal that moves. And that makes everything with more resistance and way slower. Now, the problem is that the animals that need assistance when they start taking a breath, they will need to have a peak inspiratory flow within the first 30% of their inspiratory time. And the problem, if you take, for example, a cat that needs that, we are talking about a full inspiration of 300 milliseconds. So if I have a third of that, I need my peak inspiratory flow at 100 milliseconds. And if I want my peak inspiratory flow at 100 milliseconds, that comes after 100 milliseconds, so 0.1 seconds after the animal has started to take a breath. Now, the problem is that because there is no bias flow and there's no difference between inspiratory flow and expiratory flow, the animal will take a breath that will not be detected quickly enough by the ventilator because it still needs to generate more pressure than it would have to on an ICU ventilator, more negative pressure. The ventilator then needs to recognize the negative pressure or the negative flow, but it doesn't matter because the effect on the animal is the same, and then needs to put under pressure the bellows or the piston, and then deliver the breath. And that's, in terms of timeline, it's impossible that you get to a peak inspiratory flow within the first 30 seconds of the inspiratory time. So whenever an anesthesia ventilator starts to assist a breath with an animal trigger, the peak inspiratory flow will be too late, and that will lead to patient ventilator asynchrony, so I'm not in favor of advocating for that. I know it's very complicated, so we can take that for a specific webinar at another time point because it's quite advanced. Is there a need to wean the patient off the ventilator? I've kind of answered this question a few minutes ago. There's not really a need there. It really depends on your setting. But generally, if you want them to breathe spontaneously, you're better off stopping the ventilator because that will allow your CO2 to climb faster, and therefore that will lead to a return of spontaneous ventilation faster. At least that's how I do it. So, next question is, I had several experiences with animals with impaired liver and kidney. When surgery was finished and recovering from anesthesia recovery, the animal had seizures and unfortunately died a few minutes after. How do you explain it? Is it caused by hypoxemia to brain or anesthesia drug accumulation? But that's a very good question. It's really hard to answer that question. I will probably need a lot more information to answer this question. The reality is I have absolutely no idea. I'm really sorry. Pedro, what is your preferred strategy for alveolar recruitment and why? Very good question too. Actually, I gave a talk on this topic at the World Congress of Vet Anesthesia in September last year in Paris. I don't have a preferred strategy, and there is not a single bit of evidence that gives you a strategy better than another in any species, really, as far as I'm aware. In humans, they have, when you ask human anesthetists, they will take you to a vet paper that shows very limited difference between sustained inflation versus stepwise recruitment. I don't have a preference. It really depends on what kind of equipment I'm dealing with at the time, if I really have to do one. I must disclose that I don't often do recruitment maneuvers other than in CT scan on the request of the eye people. And if this is the case, I will probably tend to use a sustained inflation because of the way our machine is set. For patients with lung disease or lung cancer, how do you know when to ventilate versus when not to ventilate? This is hard. It really depends on the type of cancer. If it's mets in the dogs, mets in the lungs, generally there are a lot of small mets. You can stay away without ventilating. very commonly we don't have many indications for anesthesia in those animals. When it's a single bigger lung cancer and you anesthetize them to remove the lung cancer, then you open the chest, you have no choice there, you have to ventilate. So question when to ventilate or not to ventilate. I always try to have them in spontaneous ventilation in general, unless I have an absolute indication. And if I have no absolute indication, I let them be. And if I see that they struggle, they don't saturate, or they hypoventilate, then I will consider ventilation. So pretty much as every other case. In human medicine, there's a concept called permissive hypoxemia in COPD patients. Does this apply to veterinary medicine as well, particularly in patients with chronic bronchitis, feline asthma? That's a very interesting question. I'm a real anesthetist. It makes me very twitchy. In the cases you describe, chronic bronchitis and asthma essentially are expiratory issues. In anesthesia, it's really never an inspiratory issue. It's an expiratory issue. So the way I deal with those cases and the way the community tends to deal with those cases is simply by increasing the duration of the expiration. And in the vast majority of cases, just by increasing the duration, having a very long expiration, that is sufficient to avoid any problem without having to tolerate hypoxemia. So personally, I don't tolerate hypoxemia at all, with the exception sometimes of horses in dorsal recumbency, in colics, and specific cases. In small animals, I don't use permissive hypoxemia at all. No. And in horses, I'd argue that if I let them be hypoxemic, it's not permissive, it's just that I give up. So I think I went through all the questions in the Q&A, and there are a bit more in the chat. Can you give a simple strategy for anesthesia during diaphragmatic hernia or tear? In diaphragmatic hernia, you have to be very, very careful because there is one condition that is called re-expansion pulmonary edema, and that's re-expansion pulmonary, not necessarily in traumatic diaphragmatic rupture, but in more chronic or congenital diaphragmatic hernias. But it could also happen in cases of diaphragmatic rupture post road traffic accident and so on. What we need to do in those cases is really to try and use the lowest possible alveolar pressure, if you like. So all in all, what we can monitor is try and use a low inspiratory pressure. So I'd say my only strategy in those cases is I give enough to maintain saturation, and any pressure that goes above 8 to 9 centimeters of water makes me a little bit uncomfortable. So I'd say regardless of the type of ventilator you use and pressure control ventilation or volume control ventilation, I like to stay below 8 to 9 centimeters of water whilst maintaining saturation. I may go above that if I really can't maintain oxygenation with those values, but most of the time your diaphragmatic hernia and diaphragmatic ruptures are in cats, and cats are fairly compliant with overall. Those cases also tend to have healthy lungs unless they have massive pulmonary hemorrhages and contusions, and those ones don't really do well anyway. But yeah, I stay low with the pressures would be my answer. Another question is, in case we are dealing with atelectasis in anesthesia, what mode should we choose? You will always deal with atelectasis in every single animal in anesthesia anyway. You may or may not detect it, that's another issue, but you will see it in every animal. There are three mechanisms to that and three reasons. The reason number one is gravity and compression atelectasis, the weight of the abdominal organs, the weight of the blood in the lungs that are above the region that becomes atelectatic and so on. Your second mechanism is the fact that by changing the nature and the humidification of the gas, as well as changing the secretions in anesthesia, you will impair the function of the surfactant, which is designed to keep the alveoli surface tension and therefore keep the alveoli open. And the third mechanism is called absorption atelectasis, and that's because of the change in the nature of gases you give, probably by increasing the internal fraction of oxygen and therefore reducing the nitrogen, together with the muscle relaxation that causes a transient collapse of the airway, which means that the minute volume to some alveolar unit may not be sufficient to keep them open. So you will see atelectasis in every single animal. One of the ways to deal with atelectasis is to add positive end expiratory pressure, which you have seen throughout the presentation as written in PEEP. I didn't really have time to talk much about the PEEP, which is adding a layer of complexity. The idea of keeping positive end expiratory pressure is to try and keep the alveoli a little bit open with pressure. I'd say yes, you probably can use PEEP. How do I deal with atelectasis when it happens? And God knows how commonly it happens. I deal with it only when it becomes a problem. So when I really struggle to maintain saturation, and otherwise, in the majority of animals we see in small animal anesthesia, I ignore it. For very small patients, like 1 to 2 kilogram dog, if a non-rebreathing system is unavailable, what ventilator setting would you recommend when using a rebreathing system? Whoa. It depends on the type of equipment you have. I'd still recommend you to use a non-rebreathing system, so make it available. There are very few machines that don't accommodate that. The only thing I can think about is probably the GE Garsation 650 in Sweden that were sold without an auxiliary common gas outlet. But most of the time you can squeeze a non-rebreathing. If you really can't, it depends on the capability of your ventilator. Some ventilators will be able to give you a 10 to 20 mils tidal volume, which is what you would need for a 1 to 2 kilo dog. And some ventilators simply won't let you do that and will have as a minimum tidal volume probably 30, 40, 50 milliliters. In which case you have very few ways around it. Your only way around it really is to use pressure control ventilation. So that's not what I like to do, but that's what I end up doing by default because I don't really have any other option. What questions have I missed? What are your thoughts for surgeries that last for more than 3 hours and on the ventilator throughout? What are my thoughts? I'd say probably normal life for me in orthopedics. No major objection. More than 3 hours when they're on the ventilator throughout, I'd say the case will become a little bit boring, but that's pretty much it. I think I've answered all the questions I can see. What about C-sections? What do you want to know about C-sections, about the ventilation in general for a C-section? That's a tricky one. You need to be well, C-section I tend to use volume control ventilation with a tidal volume of 10 mils per kg. And I will probably use ventilation in a lot of them because when you put them on their back, if they have a lot of puppies in the uterus, that will move the diaphragm very cranially, and that will make them very prone to developing hypoxemia because you reduce the functional residual capacity. Generally, they have healthy lungs, regardless of the emergency or not nature of the C-section. So I use volume control ventilation, 10 mils per kg tidal volume to start with, and I look at chest excursions. And I probably tolerate a little bit higher pressures at the beginning of the case. The CE certificate, yeah, that's gonna be for our RWD friends. I'm not competent in there. Do you have any additional question for me?
Okay, I suppose so much for today. And thanks again for Dr. Matthews today's fabulous work. And
Thank you for having me, and thank you for all your questions, because sometimes it's a bit hard online. People don't ask questions, and it's really nice to see that people kept the engagement and asked a lot of questions. I'm very happy with that.
yeah, we will after this meeting we'll record all the question and your answer together. And if you want to, if you have any other new ideas, you can add on it, and we will public in our social channel. So, dear audience, if you need more information, you can either send us an email or follow us or follow our social media account as shown in the screen. And we will announce our next academy on it. Thank you very much for today's webinar.
Thank you for having me.
Okay, no problem.